So in the blurb that I put in as the abstract, I started it by comparing it to PETCT and sort of described PETCT as a disruptive technology in the sense that when I first came to London way back in 1985, the only place you could see PET was in the Hammersmith Hospital. And now, of course, you can see PET in places like this, you know. So it really changed the way PET was available and so PET-CT, that bringing together, changed the availability of PET in the clinic. You know, you didn't care whether you saw it just as a CT with a special contrast or an isotope scan with a great localization. The clinical usefulness was very clearly made now with that, and it sort of changed. So am I overstating the case? Well, maybe I am, that this SPECT CT has got the ability to have a similar change to the landscape that we face in terms of, but as you'll see from the talks today, there is a definite possibility that SPECT CT will have a similar, big change in how we act and how we work. Certainly in terms of the number of departments that will be able to get SPECT CTs are going to be much greater. So the numbers of departments, and also the disease conditions that we're going to be exploring are also going to be greater, and you'll see that through the talks. But CT does poses questions that we maybe have not faced up to in nuclear medicine before. Well, we certainly have to rethink those questions that we had before. So the environment's going to have to be different. You know, how the shielded room and the requirements related to that is a big change in nuclear medicine. The training of our staff, again, something because it's certainly, and I should say at this stage, this talk will be very UK focused and it'll be focused on the UK legislation, but hopefully the lessons that we have learned through there are useful for anybody else who is from other parts of the country. But obviously there is the tradition in the UK where you have got the radiographer and the radiographer-led department, or the technologist and technologist-led department, and those separations, and that sort of interaction now with CT coming into the department is something that we have to face up to. And so the regulatory compliance, again, that is obviously a big issue. I mean, I'm a member of the RSEC committee as well, so also regulation is something that I take a great deal of interest in. So, like the rest of the people, I'm going to do this to try and just have a discussion, because we're now talking about how we're going to procure these things as well. And so just to usually go back through the history, not in the same level of detail, but we have the Hawkeye, which people talked about. You know, it was a great breakthrough. So it's sometimes looked at now, the images are sort of taken up and sort of quite poorly compared to some other things. But you know, it was a great major breakthrough. Even in its day, though, the CT technology in the day was backward. It was a generation behind probably the CT that was available on the machines. Maybe we're different now. No one had put up a picture of precedence. Interesting thing about the precedence was a massive machine. Left Terrace is probably one of the few people who has got experience on this. I think there's only probably 2 in the UK, not many. But you know, was that brought onto the idea that you could bring in full-blown CT. Again, so I'm not going to disparage it, I mean, but it's expensive, needed a huge amount of space. That was probably its limiting factor in the market. Symbia, I think, was a very successful machine, because you had this combination of the reasonably high quality CT and a relatively compact device. And so therefore I think Siemens in the UK probably did quite well, and the world probably did. That was seen to be, I think, almost a redefining of the thing. And it was, you had your 16 slice CTs and stuff like this. Suddenly, those CTs were not, they were not a generation behind. Well, at least they weren't at the time. They weren't too far behind, at least. The Philips Brightview has this John gave a better description, but it is a lower sort of dose sort of thing. It's got these different panels. There is advantages to this, as John alluded to. I mean, GE used to say this as well. I used to sort of think it was a bit of, this is not a bug, it's a feature. But they would say, well, there's a sort of slowness to some of the acquisitions on the old GE and the Hawkeye, which meant that you could blur it the same way as in nuclear medicine. So it wasn't so it wasn't a bug, it was a feature. So But you can't dismiss that. As John said, there is a benefit to that. But I don't know have any experience about this. But certainly on the GE, I think we were fooled into the idea with some of the quality of the images of the old Hawkeyes that actually it's a really low dose machine. It wasn't that low dose. But really, because it gave a very low output, but it gave a low output for quite a long time. So now, of course, as John again talked to, the one that I'm aware of that has got the sort of up-to-date technology, high quality CT, but the interesting thing for me on this perspective is that the iterative reconstruction, I think, is available for the nuclear medicine version of that. So iterative reconstruction on the CT, of course, I'm talking. So what I'm trying to talk about here, I've taken this definition to about long tail. I'm using the phrase, I don't know if people know about this, people like Amazon, their business model is different. You buy a book and you don't expect that you don't need the book to sell out immediately. You can wait, the book can then go on selling for 20 years afterwards. This is what I'm talking about, long tail commissioning. I'm just taking a commissioning with not just the first 6 weeks. I'm thinking about my definition of commissioning I'm talking about is something that may go on for quite a while. And I'll tell you why I think that's the case. So it's going to be about procurement. It's about planning the environment you're going to be in. It's about changing our practice, and actually, I mean that in two senses, about how it changes it when it comes in. But your practice will continue to evolve as you learn your machine, and that's not just because we've been stupid at the start, because there's certain things you won't know about until you develop a body of understanding of how much dose your machine has, what qualities associated with that dose, and can you change it. As I said to you, my interest is about keeping compliant, partly with my manager's hat on, because I'm the person to the door the inspector knocks on when they come out to inspect your farm. So I want to make sure that we've taken into account all the commissioning team to make sure we've got the right people. Obviously the clinicians, would be the physicians or the radiologists are important, but you might want to consider having your referrers involved as well. That might impact on what sort of machine you would feel you need. If you have a musculoskeletal development in your service in your hospital, you might really want to get their input. Obviously, the technologists will have to be involved because they will have to understand the workflow and the demands of the ergonomics of the machine. So you want to make sure they're fully involved in the setup. And of course, you can have that as radiographers or technologists. And then you'll have the physicists. In the UK, the key person is called the medical physics expert, but you want to make sure, as well as the nuclear medicine one, you've included the digital radiology person. That's particularly the case now when you've got these situations where you have iterative reconstruction methods on CT. CT, I think, has changed very quickly over the last few years. I think that's the one thing we have to be aware of. We think we've caught up with CT having these things in, but CT has rapidly changed, particularly about dose, which is what people are talking about. And of course, you'll need to have your hospital procurement team fully signed up, and your, what we call the project department, which is your buildings department, whoever's doing it. Just for, again, very local European or UK sort of thing, is that there's a couple of routes to do procurement. You have the official traditional one, the OJU tender, which is where all public purchases over a certain value have to be offered through this method to make sure there's no, it's open and clear and no sort of dodgy material, activities going on. So these have got very, very distinct processes that have to happen under very well-defined timescales, where the public body has to make an expression of interest that announce that we want to buy a SPECT CT. And that gets announced in this thing called the OJU Journal. And that sits there for a period of time, it's a distinct period, a defined period of time, and you wait for people to come back and say, yeah, we'd be interested in selling you a SPECT CT. And then when you've got those I think those people have to not only say, it can't just be, Dave's Cabs phones you up and says, I can sell you a SPECT CT. They have to provide you information that we've got financially viable and we can do that. And so of those people who sort of give you that interest, you then give them an invitation to tender, and they've got a period of time to which they will return the value. In the UK now we have got sort of these framework purchases systems. The biggest one is the NHS supply chain, where they have done all that OU work that was that we used to have to go through before, which was the long and tedious process of waiting for the supply department to send us out and people to come back. And you can sort of sell it as you can just buy it off the shelf. You know, you can go there, they'll give you get a price list even off them now, and they'll give you a price list of core, which is a great innovation, I have to say. So you can sort of have a better idea when you're going to your managers to win your cases. You've got a better idea what the price is. But it's very, very core price, and so you're never going to necessarily just take that up, but you might want to go through some sort of mini competition. So you might say, right, there's 3 SPECT CT cameras we want to say, let's get them in and see what else they can offer us, because the core thing will not be enough. There might be not enough workstations, they may not give you the alternatives to the software that they might have and stuff like that. And also through that process you might want to consider getting a turnkey where you get the company to say, actually not only will you supply the machine, but you'll build the department as well, because the department build can be quite expensive. And that you can play the two of those off together, the cost of the machine and the build. But the real thing that you should be interested in is putting in your user requirements, and that team that we talked about at the start would be very important to identify what those are. And there's all these different ways that you can do. What output are we wanting out of this tender and these devices? What do we want to get out of this? And that's the real key thing for you to do that for all of us, well, you know, all the people involved here. The difficulty about it is how you weigh these responses, because you can end up having a huge document. And you might think that this is valuable, and how important is the CT dose as opposed to the ergonomics of the bed. So these are not as easy to simply sort of measure up, but it'll all add up. But there will be specifying mandatory requirements which you think are sort of de rigueur that things must have. But of course procurement will have views on what's mandatory and not. And they'll also have clear ideas about how you have to score systems. They'll have financial and standing instructions which will make demands of them about what they can ask for and what they can't ask for. And there'll be this question at the very end about, are you going for best value, or are you going for cheapest? And I think for these machines, if you're talking about buying 100,000 syringes, you can probably just go for cheapest. But when you're buying a SPECT CT, you can hopefully win the case for making best value. Which means you might go for a better, more expensive machine, but the value of it and what you can deliver in terms of the quality of the care to the patient will add into the value of it rather than just the price. So let's get on to really into the regulatory things, and what you have to make sure you're covering is the first thing, once you've assumed you're started down the road and you're buying it, you then have to start designing your room. And this is a really important thing. And this is where I think it's a bit of a game changer in nuclear medicine, because it means we have to start with a clean slate again and really rethink things through. And that's starting off by going through the prior risk assessments. Because we found that when we did it, we thought, oh, we need a CT, it's not going to be a shielded room. But of course, once we started to do it, we realised that when the question was asked, and it was asked of Dr. Buscombe there, when it was with then he was Dr. Buscombe, it was, well, what else are you going to be doing in there? And John very helpfully said, oh, we're going to be doing 10 gigabits of iodine 131, and we're going to do 5 of them every day. And of course, the RPAs went, oh God, and started to shield for that as well. So you notice that some things we may have ignored in the past by saying, oh, it's just a nuclear medicine scanner, stick it in there, don't worry about it. Well, actually, you have to start taking into account the effect of your especially your high dose patients. So it does make you rethink of all your activity. Just as a wee aside, who are we protecting? Of course, we are going to be protecting the public, i.e. you mean the person walking past your scanning room and your staff. I think one interesting thing we had got into a conversation about is, what do you do about adjacent radiation workers? And the question was debated about is we had butted our pharmacy department, and the pharmacy office was right beside it, and people were saying, well, you don't need to protect them as like members of the public, because they're radiation workers, so you don't have to set the same standard to them. Usually the radiation workers are allowed to have a wee bit more. You don't have to go to the same for the public. Which, of course, I said that's not really fair, really, is it? Because they're not a radiation worker. Why is a radiation worker allowed a wee bit more radiation? Well, you think it's probably because they know how to control their dose. They're actively involved. But sitting in an office beside a CT machine, they have no knowledge and they can't do anything. So you're actually protecting the public, really. And the thing is, of course, you're measuring is how you build your systems. You build them on dose constraints, not on just the limit. So that's a 0.3 of the appropriate limit. So for public, that's 0.3 of millisievert a year. And so what the companies can supply you with, and this is great for the RPA, is an isodose curve. So they'll show you what radiation dose the CT will be giving. So that's one of the key documents that you'll have to find. And that will inform the RPA where to structure the shielding for the camera. So a control room will always be essential in this because most of the machines now are quite proper CT machines. But you need to clarify the entry and access. I caused some consternation in an associate department of ours where a very eminent professor came down to see their nice new SPECT CT room and promptly walked straight into the camera room, or was attempting to, at which point I shouted at him and said, stop. And you can see all the minions around this very eminent professor going, you don't talk to the professor again. I said, start if you mean to go on. You don't walk into a CT room just like that. Go in through the control room. Obviously, you need to start that, changing that culture. And you need to be particularly changing the culture of recognizing sort of warning lights, which you don't normally use in nuclear medicine. And you need to be clear about the reasons how you decide to define the room. So the health and safety executive are very interested in making sure you know why if you're making your gamma camera room controlled, why are you making it controlled? Is it for the CT only? Are you controlling it for the nuclear medicine risk of spill and contamination? So those things you have to be clear. So that's why, again, fundamentally think your processes through. And remember, you have to think about above and below, not just because you're protecting above and below, but you can get scattered down and around your control room. So make sure you've got appropriate shielding well up to protect yourself from things bouncing around and back down into the control room. You also must make sure you might want to consider UPS. I only mention that in there because I know of another procurement where somebody went along the lines, most of us probably have UPSs on our nuclear medicine cameras now. But one company was was going ahead with and supplying the information to provide a UPS system for the CT machine as well. This was £150,000 and took it was half the size of the room. So, I just mentioned that as a sort of an interesting thing you can do that in the wrong way. So you have to change the idea of having your local rules as well. So your local rules will have to be your standard nuclear medicine stuff, whatever your choice of your RPA has agreed with you that you want to have as your local rules. But you have to add in the CT. You'll have to face the question now, particularly, will you have people in the room? Well, I would try and say no, not under any circumstances. Well, maybe if you must, you might have to do it. So we allowed the possibility of that at one level. So we got lead aprons that allowed that. But in our local rules, we often go to the extent of saying, if you need to be in the room, these are the places you should stand. Because of that isodose curve, you can work out where the best place for people to stand is. Right, into another set of legislation now, really, you want to talk about a PatientTHO strategy. So, as we know from the past, people would talk about just doing attenuation correction type of scans, localization scans, sort of full diagnostic, or the contrast enhanced. I just want to make a question I may answer in the future, in a couple of slides ahead, is localization simply just a point in 3D space? Is that what we're interested in? Is that all we're interested in? So, in terms of implementing those strategies, it might be who have you got to do the scanning for you? The available dose-saving techniques, which we've talked about before, additive reconstruction being one of the big new ones, and whether you're doing contrast enhanced. So, just to give you what our experience at the Royal Free was, we had technologists. Dose care, of course, we definitely use dose care. It'd be immoral not to use dose care, so you have to use these dose-saving techniques that are available that John identified. With ability to do SPECT-guided positioning is also quite useful. We don't have, the Siemens doesn't have any iterative reconstruction on the CT available on our nuclear medicine. I don't think they have it available in the Symbia as yet. They have it on their full bone scanners, but not that. But there's another option you can consider, and we might look into it, is that there's some companies that will supply you with a black box in which you sort of fire out your CT, and they do some sort of fancy adaptive filtering, a bit like the Pixon imaging that they sometimes do. It'll smooth out the noisiness so you can reduce your dose and you get a noisy image. So we might look into that as a sort of add-on to help us reduce our dose. So in terms of what we do, we sometimes just do attenuation correction. We do what I would call the location plus, in the sense that we probably do a wee bit more, a higher dose than strictly would need just for this positional information on 3D space. But my argument is that localization, and we've had a couple of very good examples of that, if you have a good quality CT, not only do you say where it is, but you can sort of might be able to type the tissue a bit, or a good radiologist will be able to say, I know from the look of the CT it's in that type of tissue, it's in that type of body, because that's the sort of what it looks like on a CT. And we do full diagnostic on our MSK stuff, because our referrers said when we ask you for a hybrid MSK, we really expect to get a proper diagnostic MSK scan as well. And our technologists have to strictly, because we have good technologists, we do strictly make them conform to protocol. We had to start off somewhere, and we made a decision that we would make. I sort of said we should decide that we'll never go beyond 50% of what we do in digital and the diagnostic radiology. We didn't want to be anywhere near that. That was a sort of the benchmark that we sort of set. And when we did an audit, we set things up. When we did an audit, we were actually about 20 to 30% of that for most of those. And this is where, to do this, though, we needed the support of the team, from the diagnostic radiology team, physics team, and they did all these fancy calculations for us that allowed us to work out the doses. And just to talk to us what John was talking about, the care dose thing varies the dose to allow you to get a sort of continuous image quality, depending on whether the patient you're scanning is thinner or fatter than your reference person. Because we're after dose optimization. We're not just trying to get the minimum dose, we're trying to get the optimal dose for that patient. And this is where then, those dose-saving techniques have to be helped by guiding from a topogram, because they look at the thickness of the patient, and those are the things that help you define it. They also do it on the fly by saying what was the previous slice. But what we have, the technique we also make use of in nuclear medicine, they're all free, is the SPECT guided. So we've already done the SPECT, and the reason that's important is we make sure that we don't ever CT more than we have in the nuclear medicine image, because obviously there's no point in doing that. So that's the SPECT guided. I think it's a nice technique to be able to implement. Just want to address the technologist issue because of the nature of the UK. So what did we do with that? Well, some of our guys were trained abroad, and that separation between between radiographer and technologist wasn't the same. And they had been experienced SPECT CT users, so we were a wee bit more relaxed about that. We organised some theoretical training. We got an outside trainer in to make sure we did that. We had our own radiation safety team come in and do diagnostic radiology team and come and do that as well. We set up a very clear competence list they had to complete before they could do some of the types of tests on the machine. We made sure we consulted with a lead CT radiographer, which was a bit political as much as anything, but nevertheless, that's what we did. And we have update training, and we have incident feedback. We always talk about no blame culture and stuff like this, but this it worked really well with us. We have changed our practice. We have things where our guys were probably not as clear about the protecting of the eyes when they were doing a neck CT. So we've had things like that. that maybe a radiographer would have known, but we hadn't had terrible incidents. I don't think, given my experience of working in other hospitals and other centres, I don't think we've had many more incidents in RCT. In fact, we've probably had a lot more less incidents related to RCT than I've experienced in straightforward radiology departments. So it definitely can be done that you can train this. And a key thing is that we have no ability to vary the CT protocols. And we've also got something called the pink form, which you'll see in a moment. So we support our technologists by making very clear what the protocols that they are abiding by. But of course, it's not just for the technologists that we're interested in. You need to have very clear, so the practitioner under IRMA has to start thinking about their justification criteria. And it goes back to this question about what level of CT dose do you want to apply, and is it justified? And we've now gone, for instance, as an example, our MSK stuff, we feel it's justified to give a good quality CT for those patients, because that's what the clinical questions are being asked of us, and it's justified on that basis. You also have to have some sort of authorization protocol, so that the CT radiologist may have decided, yes, this is what we're going to do, but you're going to have to make sure that authorization, its protocol, is well written out and is complied with. You might also need to have one that's in scan. How do you deal with the in scan? You know, the bone scan that comes along and there's a suspicious lesion and somebody says this might work well with the CT. So you need to have that needs an authorization process as well. So you need to be clear about that. And so the communication and recording of all of this is important. To help that, we have created this listing of the dose investigation levels and the doses of all the scans. So our radiologists and our nuclear medicine physicians know when they're signing up to a CT what dose these patients are going to be getting. And we've also got these measurements of the DLPs, etc., which our machine puts out to help our radiographers and technologists know what doses they've given. So this is the aforementioned pink form. The observer didn't realize it's not pink, but obviously we printed it in pink paper. But this allows our people to identify the person who's justifying this or authorizing this. Tells people what type of scan they want, even to the extent of identifying the limits of where they want the scan to go. So the other bits of compliance we need to run through quickly is you need to record the dose. Quite often this is all you'll get. You'll get some sort of prescription at the end, and that has to go through. That will improve hopefully in the future. I mean, that's what in Internship Procurement you should be asking questions about this, because the IHE is trying to produce these profiles that can accurately record this. The key thing is to make things auditable, and to do that we put all our doses into an Excel spreadsheet. That's where we do that because dose recording is important and it allows audit. But it allows audit more importantly so we can get diagnostic reference levels. And that's why I said before about how you will only learn. You'll only get your diagnostic reference levels once you've done a body of work, because then you'll know what sort of studies you're doing, what you expect to get, and then you can work out what your incident levels are as well. The other thing you could consider doing, of course, is not just doing it from the dose level, but looking at the images and seeing if you can reduce the doses and see if you can keep the images. That can be, still get the information. That can be difficult because just the numbers of patients you get through nuclear medicine. So just making an arbitrary decision may take you too long to decide whether that's appropriate for all your patients. We have done this on some scans and it has worked okay, but you could consider doing phantom scanning. You'll be glad to know I won't talk too much about acceptance testing, but that is a really important bit, as John particularly talked about. It is the misregistration issue that you might want to worry about, and so all the companies will have some systems. But you will need your CT person to come in and do the CT acceptance testing as well. Some miscellaneous things, especially for the UK, handover forms. HSE is very important. Do you have a system now in place to rethink your handover form? This is really important on CT. You have to worry about what happens if your protocols are changed. That can have a major effect on your doses. One issue would be interesting to know is, do you need to inform the HSE that you're intending to use SPECT CT? If you're not, hadn't got a SPECT CT before, do you need to inform your local office? That was something we were told we had to do. I phoned the local HSE office, they hadn't a clue. But I sent them a letter anyway. And the other thing might have a big impact on you is, do you have a policy about unexpected findings? You know, for a nuclear medicine department, you know, you probably didn't think of that in the same way. But now you're doing a scan, and you're doing a musculoskeletal scan of the chest, and you suddenly find lesions in the lung. Do you want to be in a position that somebody does 6 months down the road, comes and has a CT and says, why didn't you see that then? So these are things that have a big impact on you. So in summary, the key regulations need to be looked at afresh, and it does give you a chance to look at them from not from the CT, but for everything. The technology you've chosen will affect how you can comply. The way your department workflows are going to be severely impacted, particularly by the reporters, because of the reporting physicians. There's a lot of CT images that you may need to do if you want to be worried about the quality of especially on unexpected findings. It is an iterative process. It isn't just stupidity on our part. You need to build up a body of information before you can go back and do it. And that's why training, audit, and review are really crucial. I mean, this process actually has made it clear to me that the legislation identifying all these things actually does work well. Because if you go through those processes, you will not only really help to keep the regulators happy, but it actually will make your practice better.